This morning, we have two wonderful speakers joining us for a combined presentation, so that's very exciting. First, we have Jackie Powell, who's our first-year maternal fetal medicine fellow here. As many of you know, she completed her medical school at the Medical College of Wisconsin and then OBGYN residency at OHSU, which is also where our second presenter is from, Lawrence Moore. He is the American Medical Foundation LGBT Fellow of the Department of Family Medicine and Community Health here at UW. He did his medical school and residency training at OHSU and then worked at a FQHC in rural Southern California before joining us here. So we're very excited to have both of them here to present this morning.
Hello, everyone. Can you hear me? Yes? Okay. All right. So we are going to present on HIV care and prevention in obstetrics and gynecology. Thank you for having us. Thank you for joining us. We will describe epidemiologic trends. We're going to describe some well woman care for people living with HIV. We're going to talk about HIV during pregnancy and some considerations for delivery. We're going to talk about intrapartum management, there we go, and then talk about transmission prevention and HIV PrEP. So here is our agenda. In brief, let's start with thinking about the virology of HIV, just a very brief review. So HIV, it's a lentivirus, it's a retrovirus. We have our single-stranded RNA surrounded by the capsid coat, which is made of P24 proteins, very important. And then that's surrounded again by a bilayer, a phospholipid bilayer with some of the attachment proteins on the edge, the GP120 and GP41. This is the life cycle of the virus. As you can see, it joins the CD4 receptor on lymphocytes, then dumps in the RNA, and then that gets reverse transcribed by reverse transcriptase into DNA, which then gets integrated into the viral DNA gets integrated into the host cell's DNA, which then produces more RNA, produces the proteins get all cut up by protease, and then that forms the new virions that are pumped out and shed and can infect new cells. Lots of different stages. I know it's very confusing, but it gives us a lot of points for pharmacological prevention. So that's kind of one of the key components, is that we have a lot of different points where we can intervene during this life cycle to prevent transmission. All right. Stages of HIV, very brief, and I know I'm going very fast, so if anyone has any questions, please feel free to ask. But in the acute phase, this is stage 1, after people are acutely infected. In the black line, you have viremia, and in the dotted line, you have the CD4 lymphocyte count. So initially, after the acute infection, someone may have some non-specific symptoms, fever, maculopapular rash, diarrhea. They may have no symptoms. And that's when the viremia goes really, really high. And that's when we see people with, viral counts in the millions, tens of millions. And initially, CD4 count may dip somewhat, but without treatment, the natural course of the disease, the immune system will mount an initial response, and the viremia will reduce over time as the person goes into stage 2 of HIV. The CD4 count recovers somewhat, but over a long time period of maybe a decade, plus minus, that CD4 count will start to decrease again, and viremia will increase. And that's what leads into the last stage, stage 3, which is AIDS, where people will have some of these opportunistic AIDS-defining infections. Okay. After someone is acutely infected with HIV, we have timelines when different antigens and antibodies start to present themselves, when we can start to detect them in serum. The HIV RNA is the first one that becomes detectable. That is about 10 to 11 days after someone's initially infected. Antibody response takes a bit longer, up to 24, 25 days. So if you see someone and they've had a recent exposure, it may be too soon to see an antibody response. If they just had an exposure maybe 5 or 7 days ago, it may even be too soon to see a viral load response. So you may have to wait a bit before you test them, and you may have to get a viral load as an initial test. Here is similar information in another format. Soon, we have the eclipse period. That's the kind of initial incubation period, if you will. It's about 10 or 11 days. And that's when we start to be able to detect viral load. And then the antibody takes much longer. That's, again, 24, 25 days. The P24 antigen, remember, that's the protein that's, P24 is the protein that makes up the capsule, the capsid, that surrounds the single-stranded RNA. That takes about 15, 17 days. So here is a testing algorithm. This is the testing algorithm that's recommended by the Association of Public Health Laboratories. Our initial test is an antigen-antibody reflex test. So we're testing for the P24 antigen again and the antibody. And that will be able to pop positive probably 20 days-ish after someone's been infected, one of those two, but very reliably after 25 or 40 days, will that be positive? If that's positive, then we go for a differentiation test. So if you order this test and one of them tests positive, the lab will reflex to an HIV 1-2 differentiation test. And if those are both negative and you have some ambiguity in what the testing is showing you, then the next test would be a viral load that you could order. But the lab may not reflex to that necessarily. You may have to add that on or order it separately. Okay, let's transition into talking about epidemiology. So every year in the US, there's about 6,500 new incident HIV infections among women. There's in total about 32,000 total HIV infections. 18% of new infections in the US are among women, which is the opposite of what the case is in Africa, where it depends what country you look at, but about 60 to 70% in some cases of new infections will be among women. How are people catching HIV in the US? Women are catching HIV primarily through heterosexual contact, a minority through injection drug use. There is a huge disparity, unfortunately, with the incidence of HIV among people of color. As you can see here, 54% of incident infections were among African-American people, 19% among Latinx people. Here in Wisconsin, most infections are in the metropolitan areas, Milwaukee and Dane County, but they do occur throughout the state. Here again is a chart showing the incident infections by race here in Wisconsin. And you can see that, again, here in Wisconsin, we see this disparity with a disproportionate number of incident infections among people of color. We won't talk very much about transgender women, but it's worth mentioning that the CDC estimates that of urban transgender women, about 4 in 10 have HIV, and among African-American transgender women, that number rises to over 6 in 10 about. So it's worth noting that there is a huge epidemiologic risk among transgender women. And I'll leave it at that. Okay. This again is these are numbers from here in Wisconsin. If you focus on the right-hand side, you will see that the incident infections among African-American women are 30 times that among white women. And that reflects numbers nationwide. When we diagnose someone with HIV, kicks off a whole process of wanting to refer people to HIV care. So getting them referred to an HIV clinic, starting them on medicine, making sure they're retained in care. HIV clinics have a lot of funding from the Ryan White Fund to be able to support and maintain people in care. So there's a lot of focus on social work. For example, there might be food pantries in HIV clinics. There's a lot of outreach workers. And the reason is that we want to really be able to make sure that people get their medicines, that people don't have problems with transportation, people don't have problems, with childcare, et cetera, et cetera. So that's what this shows. This is a reflection of this is a chart that shows you the HIV kind of linkage to care here in Wisconsin. So here, if we have 100% of people diagnosed and living with HIV, 79% of those are retained in care. Sorry, 79% of those are in care, 54% are retained in care, and then 71% are virally suppressed. That's important because the gap, that 29% gap of people who are aware of their diagnosis but are not virally suppressed, account for about 40+% of new infections. So we're doing a good job. These numbers represent nationwide figures. Nationwide, about 70-ish% of people who know that they have HIV are virally suppressed. Our goal, though, is 95%. There's been a lot of progress over the years. As you can see here, over time, a lot of people with the advances in antiretroviral therapy, with the advances in being able to link people to care, being able to live longer lives, get to viral suppression, and they're not dying of the HIV-associated diseases and deaths that were common in the 80s and 90s. People are living longer. Median age now is well into their 50s, and if with good viral suppression, people can expect to live longer than that. So I will hand over to Dr. Powell to talk about HIV in obstetrics.
All right. Good morning, everyone. So I'm going to do a pretty rapid overview of HIV and obstetrics. This could be a grand rounds talk in and of itself, but due to time, we will just make sure to hit upon some of the key points. So in terms of screening and pregnancy, we do this with our initial obstetric labs, as I think we all know. This is an opt-out approach, meaning that we recommend it to all patients. And if they decline the test, they need to have appropriate counseling and have that documented clearly in their chart. It's important to note that there are certain populations of people that we should actually repeat HIV testing in the third trimester. Those would be people who are receiving care in facilities with HIV and pregnancy incidence of 1 in 1,000 per year, patients who are incarcerated, those with signs and symptoms of acute HIV, which is like fever, generalized kind of flu-like symptoms, maculopapular rash, lymphadenopathy, and then those people who reside in jurisdictions with elevated HIV incidence. That is not us here in Madison or in Wisconsin. That tends to be more in the northeast and southeast parts of the country. And then, of course, if somebody comes in with an undocumented HIV status and in labor, we would need to perform an expedited test for them at that time. In terms of the HIV diagnosis being made in pregnancy, this is generally with a positive 4th generation test. And that 4th generation test is what Dr. Moore mentioned. It's the P24 antigen and antibody assay. This does need to be confirmed with follow-up testing, though, as there have been case reports of false positive tests in pregnancy. So we confirm that with a viral load. And then additionally, you can do the HIV antibody assay as well. Like I mentioned, there have been these case reports of false positive 4th generation testing in pregnancy. A study out of UT Southwestern at Parkland actually looked at over 21,000 patients, and they used the Architect combination assay. That's just their brand for their 4th generation test. Their results show that there was a sensitivity of 100% and a specificity of 99.8%, which is overall comparable to the non-pregnant population. And so I think it's just important to note that while we kind of hear about more false positive tests in pregnancy, it's probably just because we're screening more people than the general population. I wanted to go over what specific testing we have here at Meritor. So we only have the 4th generation test, and this can be run as a rapid test. And the definition of a rapid test means that the result has to turn around within less than an hour. There are other rapid tests like a saliva antibody test and things like that. We don't have that available at Meritor. On the weekdays, the lab will result in less than an hour, but it's important to note that on the weekend, there's nobody actively in the lab who is running the quality control on the equipment. And so it may take longer than an hour for patients who, if they show up kind of with no prenatal care and in labor on the weekend, this test will have a slower turnaround time. Next, we'll talk about transmission risk in pregnancy. So HIV transmission can occur at any stage in pregnancy, but there are times when it's higher risk. Without antiretroviral therapy, the estimated probability of perinatal transmission is 25%. Of cases of perinatal transmission, 20% occur before 36 weeks gestation, 50% between 36 weeks and delivery, and then 30% during active labor and delivery. And these are all for people with a positive viral load. Of those patients with a positive viral load, administering IV zidovudine before delivery and for 6 weeks of life for the neonate can decrease this transmission risk to 8%. With interventions, meaning prenatal care and antiretroviral therapy to achieve a suppressed viral load, the overall risk of perinatal transmission in the US is less than 1%. And so we have fewer than 100 cases of perinatal HIV transmission in the US annually. I'll next go over some key points for antepartum management. There are a lot of things that could be covered here. And I want to point out that SMFM has a really great clinical guideline that has these checklists for the different parts of pregnancy. So they have it based on the first prenatal visit, first and second trimesters, third trimesters. But for time reasons and to not just go through a checklist, I'll go through a few of the key points, but I think this is worth looking at if you have some free time. The overall key points is just that we are checking viral loads and CD4 counts very frequently. So we check it initially in the first trimester. This is also time to make sure patients are up to date on their vaccines, and then addressing any nausea, treating that really aggressively because we want patients to be able to keep down their antiretroviral medications, and addressing any barriers to adherence with their medication regimen. In the second trimester, we're continuing to check these viral loads and CD4 counts monthly until negative, and then we can space it out to every 1 to 3 months, continuing to address nausea and barriers to adherence at every visit. And then in the third trimester, we want to make sure even if patients have had negative viral loads leading up to this, that we're retesting them at 34 to 36 weeks, as this helps us guide delivery planning. We'll briefly review just some core principles of antiretroviral therapy in pregnancy. All pregnant people should be initiated as early as possible when we're making this diagnosis during pregnancy. But if they already come in on antiretroviral therapy, the same regimen should be continued as long as it's effective and safe in pregnancy. We are fortunate enough to have ID colleagues here who can help us kind of determine what are the appropriate medication regimens that they're on, but there are certain ones that have well-studied pharmacokinetics in pregnancy, and others might not be as effective. Our overall goal is to achieve an undetectable viral load. And then when we're counseling patients about taking these, their antiretrovirals with other medications commonly prescribed in pregnancy, there are some that can interfere with absorption. So patients should space out their antiretroviral medications with their prenatal vitamin and with any acid suppressive medications to make sure that they're absorbing their antiretrovirals. Now we'll move on to intrapartum management. As I mentioned before, management depends on a viral load, which should be checked at 34 to 36 weeks to create a delivery plan. If a patient has a viral load of greater than 1,000 copies per milliliter, our recommendation is for a C-section scheduled at 38 weeks, with IV zidovudine starting 3 hours prior to that with a loading dose and then a continuous dose following. If a patient opts for labor, we would continue the same antiretroviral regimen with them moving through labor. And while we're giving them IV zidovudine, we should still be giving them their oral antiretroviral medication regimen. If a patient has a viral load of less than 1,000 copies per milliliter, then labor and vaginal delivery is safe, and the timing should be per obstetric indications. So an induction at 39 weeks, while we do it for a lot of our patients, that in and of itself doesn't necessarily decrease the risk of perinatal transmission. And then whether or not to administer IV zidovudine for people with less than 1,000 copies per milliliter is a little bit controversial. ACOG states to use clinical judgment in these scenarios. Here at Meritor, we have all of the resources available to us, and so we give it to everybody who has HIV. When you look at transmission rates for the different viral load amounts, less than 1,000, for people who had less than 50 copies, the transmission rate was 1%, whereas those with 50 to 999 was 1 to 2%. This isn't statistically significant, but I think it's important just to make a comment of when we're thinking about whether or not to give patients IV zidovudine. And then I wanted to point out this really great consultation line that you can call if you're ever managing somebody on labor and delivery or even in the outpatient setting, and you have questions about how to manage them. There's a National Perinatal HIV/AIDS Clinical Consultation Center. This is through UCSF, and they are available for anybody to call them if they have any questions with taking care of their patients. I wanted to touch upon rupture of membranes, as This is something that prolonged rupture of membranes and the risk of HIV transmission has been debated in the past. There have been some recent studies that have looked at duration of rupture and the risk of transmission with a viral load of less than 1,000. And it showed that a duration of rupture of greater than 4 hours was not a risk factor. Now, that's not very long for a rupture of membranes, but in this study, while there were only a few people who had duration of rupture of greater than 25 hours or more, there were still no cases of perinatal transmission. Ultimately, our national guidelines state that artificial rupture of membranes should follow standard obstetric indications, but be avoided if possible if RNA is greater than 50 copies per milliliter. I think we can't always avoid rupture of membranes when we're moving somebody forward in their induction. And so it's kind of a case-by-case scenario when you're considering what to do next. An FSE is something that we use commonly in labor and delivery, but we try to avoid that for patients who have HIV. The data behind this is based on pre-antiretroviral therapy era. So when people had high viral loads, they showed that there was an increased risk of perinatal transmission. We unfortunately don't have great data on patients who have an undetectable viral load and received an FSE because we generally try to avoid it. So our national guidelines recommend still avoiding FSE placement. And then operative vaginal delivery, we should follow the standard obstetric indications, but avoid it if possible if somebody has a viral load of greater than 50 copies per milliliter. And then if you're managing a postpartum hemorrhage for these patients, it's important to try to avoid giving Methergine, and this is because protease inhibitors and Methergine interact. So protease inhibitors inhibit CYP3A4, which is what metabolizes Methergine. So you can ultimately have a provoked exaggerated vasoconstrictive response if you give these two medications together. For postpartum management, one of the most important things is to make sure the pediatric team is aware that you're delivering a baby to a birthing person who has HIV. And so typically we do this by alerting the pediatricians on when a patient comes to labor and delivery so that they can establish a pathway for neonatal treatment within 12 hours. We should obviously continue the birthing person's antiretroviral therapy, discuss barrier methods in addition to any other contraception. At the postpartum visit in the outpatient setting, we should make sure their pap smear is up to date, as there are some slightly different guidelines for pap smears, which Dr. Moore will go through in a little bit. And then make sure that we have transition to long-term follow-up with an infectious disease specialist and primary care provider. Typically, these patients should be established during their pregnancy, but just making sure that they have adequate postpartum follow-up. Next, we'll talk about breastfeeding for people living with HIV, as there have been some new guidelines on this recently. So for people with a negative viral load, it is recommended to do shared decision-making in terms of infant feeding choices. So replacement feeding with formula or donor milk completely eliminates the risk of postnatal HIV transmission. But for people who have a suppressed viral load during pregnancy and postpartum, the transmission risk for breastfeeding is less than 1%, but not 0. And so we often have these conversations with patients prenatally during their prenatal visits so that we can make sure we come up with a good plan for them postpartum. And we should support individuals with a sustained undetectable viral load in breastfeeding if they choose. There will be additional surveillance that's needed both for the neonate and for the birthing person in the postpartum period, which we'll go through in a moment. For people who have a positive viral load, we do not recommend breastfeeding. But if somebody chooses to breastfeed, even when we don't agree with it, engaging Child Protective Services is not an appropriate response to people's infant feeding choices. So if someone decides that they want to breastfeed, we'll need to check their viral load every 1 to 2 months while they're breastfeeding, and I'll make sure that there's a clinician following them. I think this is important, as sometimes the postpartum care, we see patients for 6 weeks and then we tell them to follow up with their PCP, but there can be a little bit of a time gap in terms of who's kind of primarily managing them. So making sure that somebody is taking ownership of those viral loads. And we also recommend exclusive breastfeeding for 6 months of life. And this is thought to be because if somebody is breastfeeding and using formula, it can potentially irritate the gut of the neonate, and there can be a potential increased risk of transmission in this setting. We also should avoid rapid weaning, as this is associated with an increased risk of HIV shedding in the breast milk. And then it's important that these patients know that their baby will require antiretroviral prophylaxis during this time. And then I'll hand it back over to Dr. Moore.
Right. Does this clicker work? No? No, not sure. Let's see. All right. So HIV primary care. So I'm a family medicine doctor, and this is kind of what I really, really love about HIV primary care. So here's some tenets that kind of I always am trying to keep in mind when I'm seeing someone who is living with HIV. If they are not on an antiretroviral, we need to get them on an antiretroviral, get them to viral suppression as soon as we can. That's what's going to prolong their life. That's what's going to keep their virus at bay. It's what's going to prevent any of the outcomes that we don't want. Number two, many people living with HIV live with some difficulties in their life. Many people around the world live with difficulties in their life. But in this case, those difficulties with transportation, difficulties with childcare, difficulties getting to the clinic, those can actually impede their viral suppression. So we want to make sure that they're working with social workers, that we're getting them bus tickets if we need to make sure that we can get them the meds that they need. Next, HIV, even when virally suppressed, is still a state of relative immune suppression. We'll go into that in a little bit more detail in a bit. And we're starting to understand that HIV, again, even when virally suppressed, there's still this low-level chronic state of inflammation that can still put people at risk for more cancers, prolonged kind of outcomes with HPV, as we'll go into. So things that we are thinking about, people are at increased risk for cancers, both AIDS-defining and non-AIDS-defining, cardiovascular disease, HIV being an independent risk factor for cardiovascular disease. Some of the meds that we're giving them put them at risk for hyperlipidemia, diabetes, renal disease, osteoporosis. We're checking a DEXA scan, and we're giving people vitamin D to be able to make sure that bones don't become too brittle, especially after the age of 50. Menopause, HIV is an independent risk factor for early menopause. Interestingly, there's a dose-response relationship with kind of CD4 count and viremia. People with CD4 counts below 50, they've been observed to have threefold increased risk of early menopause. All right, so the antiretrovirals we give people, unfortunately, these have side effects. They're great medicines, but they can put people at risk for hyperlipidemia. So we're monitoring lipids for people on certain antiretrovirals. Renal disease, we're monitoring creatinine pretty frequently. And then osteoporosis, we're checking DEXA scan. These are just some of the things that we're thinking about. Immune suppression, especially if we can't get someone virally suppressed, we are unfortunately seeing some of those opportunistic infections that we all know about, and some of the AIDS-defining illnesses and cancers. And then another unfortunate thing that we have to help these patients with, they're at risk for some substance use disorders, mood disorders, and unfortunately intimate partner violence. So cancer screening, I'm a PCP, I love cancer screening, and people with HIV are at higher risk of non-AIDS defining cancers. We don't have specific guidelines for breast, colon, lung, prostate cancer screening for people living with HIV. There are certain guidelines for cervical cancer for people who live with HIV. At entry to HIV care, people should get a pap smear. And if the cytology is normal, they should get a pap smear every year for 3 years after that before it relaxes to less frequent monitoring. And then there's an entirely separate set of guidelines for cervical pap smears and when to refer to colposcopy, in which cases, so for example, it starts at 21, it doesn't end at 65. And there's some cases where even young people with low-grade dysplasia should be referred to colposcopy, which is more, there's more frequent testing and there's an earlier referral to colposcopy. That's kind of the general gist. They're not in your ASCCP app, unfortunately. There's like a whole separate set that you have to kind of go and look up. But those are some of the tenets of those guidelines. And now anal cancer. This says no consensus, but stop the press. In review now, soon to be published in the Journal of Lower Genital Tract Disease, there will be guidelines about anal cancer screening, anal PAPs. So we'll go into that in just a second. So I'm very excited about that, as you can tell. Cholesterol. So the REPRIEVE trial was a very big trial that was published earlier this year. It was looking at the cardiovascular risk and risk reduction in people with HIV who have low or moderate risk for cardiovascular disease. So these are people who we would not put them on a statin, usually given the current guidelines. But 31% of this population were female in this study, and they were given a statin, pitavastatin, which honestly is not a statin that anyone uses, except that it has no interactions with other HIV drugs. So that's why they used it in this trial. And they saw a 1/3 reduction. Oh my gosh. They saw a 1/3 reduction in major adverse cardiovascular events. So the trial was stopped early and everyone was put on a statin. Is HIV an independent risk factor for cardiovascular disease? Most likely we don't have actual guidelines that will tell us to put people on statin, but we may start seeing people on a statin earlier in disease than otherwise would, and earlier in life than they otherwise would be. The ANCHOR trial, this amazing trial, this was published earlier this year in the New England Journal of Medicine. They looked at about 5,000 people on the West Coast living with HIV, and they monitored with anoscopy, they monitored for high-grade dysplasia in the anus, and they randomized people to just monitoring or treatment. Treatment being with bifurcation, with burning off, high-grade dysplasia, that kind of thing. They saw that the progression to cancer was 2/3 lower in the treatment group. And so this has led to new guidelines, as I say, which are in publication now and will soon be published. It's very exciting. So those guidelines will have us do anal pap smears annually for women with HIV over the age of 45. And then any woman with vulvar intraepithelial neoplasia 3 or higher should get an anal pap annually within a year of their diagnosis, or any person with vulvar cancer, those should get an anal pap within a year of diagnosis. There's other categories of people who should get anal paps that the guidelines will talk about. So one, for example, is people with solid organ transplants. They should start getting anal paps annually 10 years after their solid organ transplant. People with other diseases, IBS, Crohn's, autoimmune disease, that kind of thing. There's kind of a shared decision-making recommendation, but I'd be happy to answer any questions about that at the end. Preventing transmission, so HIV PrEP. So the USPSTF recommended in 2019 that we discuss HIV PrEP with people who are at risk, and they restated this recommendation this year in August, and they included in that recommendation the option to talk about the injectable Apretude. So that means that Apretude should be covered by insurance now, which it's not always, but trying our best. So who is at risk according to the USPSTF? Sexually active people who in the last 6 months have been sexually active with a partner who has HIV, who have had a bacterial STI in the last 6 months. And I think that's where we do a particularly bad job of recommending or even bringing up the option of HIV PrEP with our patients. People who have inconsistent condom use, or who maybe can't negotiate condom use, who don't have self-efficacy to talk about condom use with their partner. And then patient-specific factors, number of partners, if you're living in somewhere with a very high HIV prevalence, that kind of thing. And then, of course, people who inject drugs and who share equipment with HIV, that's a uniquely high risk factor for HIV acquisition. Don't worry about the details of this. This is the CDC's recommendation for who we should be talking about HIV PrEP with. It works out to be about the same, that people with bacterial STI, for example, in the last 6 months, we should talk about PrEP with those people. The CDC also recommends that anyone who comes to you and asks for HIV PrEP, you should prescribe them HIV PrEP, and without really asking, because you don't know if they have a reason why they might be asking it from you. And we shouldn't really second guess our patients if they've taken the time to educate themselves and they feel like they need it. So among cisgender women, we do incredibly badly with HIV PrEP. Only 10% of cisgender women in the US who could benefit from PrEP were actually prescribed PrEP in 2019. So the CDC went out and they did an estimate, and this, again, pre-pandemic, so the numbers may be different now, but they did an estimate of who should be getting PrEP according to these guidelines. People who've had a bacterial STI in the last 6 months, who actually is covered with PrEP, and people of color and cisgender women are particularly underserved by PrEP. So you can see here on the top level here, 44% of people who could benefit from PrEP but are not getting PrEP are African-American, and only 1% of those people, 7,000 people were prescribed PrEP in 2019. And there's similar disparity for people who are Latinx. We have 3 PrEP options on the far left. Truvada, once daily pill. In the middle, Descovy, a once daily pill. And on the far right, cabotegravir, which is also known as Apretude. It's an every 2-month injection. Descovy is not proven or FDA approved for use in cisgender women. There are trials ongoing, but the pharmacokinetics of it are very different to the way that Truvada is used. The injectable cabotegravir, long-acting, it does have good data for use in cisgender women. There's a very large study that came out of sub-Saharan Africa that showed that, in fact, it was actually superior to daily use of Truvada. And in part, that's because of, ease of adherence of getting the injection every 2 months. So there's other options as well in the pipeline. On the left, you'll see the dapivirine intravaginal ring. This is approved in other countries. The European Medicine Agency recommended it, and it's used in sub-Saharan Africa. It is not approved for use in the United States, which is very sad. It was removed from the approvals pipeline by the FDA and by the pharmacologic company that makes it. But it does exist out there, and there are trials of combined products which combine contraceptive and HIV PrEP medicine in an intravaginal ring. So that could be coming out soon, but again, whether it will actually be able to be accessed in the United States is kind of an open question. And then on the right-hand side, we have Sulenca, which is lenacapavir. It's a capsid inhibitor. It's a once every 6 months injection. Right now, we only give this to people who are kind of HIV treatment resistant, who have been trialed on multiple medicines and we're having difficulty controlling their virus. It's kind of reserved for those people here now, but there are ongoing trials in sub-Saharan Africa where they are injecting, say, in a village, they'll inject all the young women with this Sulenca every 6 months to try and see if there is a case to use it as a pre-exposure prophylaxis to prevent infection, which is really exciting. Initiating oral HIV PrEP in cisgender women. So I know that this group of people come to you for their primary care. They trust you. You diagnose bacterial STIs. You are able to have this conversation with people. So my hope for you is that you go away feeling empowered, that you can prescribe this medicine, or at least that you can bring it up and inform your patients that there is this option that can protect them from infection with HIV. So when you see someone and you want to start prescribing them oral PrEP, the guidelines say we should assess for HIV, which again, that's non-specific: fever, rash, myopathy, weight loss, night sweats, all this stuff. Say someone is saying, oh, no, I haven't had all that. Okay. Talk about adherence. You have to take this medicine every day. Talk about the risks and the benefits, risk being possible, but unlikely kidney damage, possible, but unlikely loss of bone density, maybe some GI upset. And then you want to get your baseline labs. Baseline labs, HIV, creatinine, hepatitis B serology, and an STD panel. And then you can just send for 90 days. And then if you don't want to own it going forward, you can pass it off to a PCP, or you can pass it off to their HIV clinic here, who would be more than happy to take over prescribing. You don't need to wait for the HIV results to come back before you can prescribe this medicine. If you prescribe this medicine, the HIV result comes back positive, we can always change or add or change, we can reach out to the patient and get them on appropriate medicine, but don't withhold medicine because we're waiting for that result with oral PrEP. Right. With each visit, the guidelines tell us that we should be monitoring for acute HIV, those questions, fever, night sweats, etc. Talking about adherence, HIV should be rechecked at 3 months, and every 3 months we're sending for 90 days of more pills. And then in cisgender women, the recommendation is that we recheck a full STD panel at all sites of exposure at 6 months. In practice, I think you'll probably just see most people who are prescribing this ordering Q3 month standing labs. If someone has diminished kidney function when you are starting the medicine, then you do need to check that slightly more frequently. And I like to emphasize this, follow-up can be done by telephone or video visit. There's enough barriers and difficulties to getting this medicine in the first place. We don't need to make people come into the clinic every 3 months. Even, checking in every 6 months or every year is fine. These are in the guidelines, so I won't belabor this. And actually, if you are prescribing to cisgender women, then it's even easier than it looks. But getting your STD screening panel at baseline, and then after 6 months, and then every 6 months ongoing. Injectable PrEP is a bit different. In some ways, it's easier. In some ways, it's a bit more difficult. You need to get the viral load before you start, and you actually need to get the result before you give the first injection. There's an oral lead-in option for 7 days, can be up to 30 days. If someone wants to kind of see how they do on this medicine, see if it agrees with them. And you need to get your baseline STA testing. The reason I say it's a bit more difficult is that you need to be able to plan to have someone come in for the injection every 2 months, and they need to get the viral load in the week before they get the injection. You need to have the results. So it's actually a fair amount of burden for a clinic and a clinical team to, get in touch with these patients, get them into clinic, and get them through all that palaver. So it's honestly, if this medicine is mostly being prescribed by HIV clinics who are really set up with protocols that they can do this. So if you have a patient, and the case study for this is, say you have a patient who can't use a daily pill, but they need protection for HIV, or they might be victimized, or they might not feel safe having a bottle of pills at home that protects them for HIV. They can get this injection, but I would say probably pass it off to the HIV clinic, and we can do this in the HIV clinic. Monitoring, as I said, we need to get the HIV viral load before every injection. And the reason is, as you can imagine, that when we give the injection, we can't take it back. It's very long acting. It actually stays in the blood for up to 12 months. And then, so as here, this is the equivalent monitoring for the injectable HIV PrEP. And for cisgender women, again, it's a little bit more, less complex. Thinking about PrEP specific considerations for cisgender women. So drug accumulates slower in vaginal tissues than it does in rectal tissues. So when we're prescribing PrEP to men who have sex with men, we can say, oh, take this medicine every day for 7 days, and then you'll have pretty good coverage for HIV protection. We can't say that for cisgender women who engage in receptive vaginal sex. They actually need to take it for 20 days daily with daily adherence. So if you can counsel for using other methods to reduce their HIV risk exposure for that first 20 days. The drug levels are much more sensitive to missed doses than they are in males. So we really need to counsel when we have a cisgender female person who's using HIV PrEP to take, if they're taking Truvada, they need to take it daily. And it has good, extensive data for safety and efficacy in pregnancy, good data for breastfeeding. The injectable cabotegravir, it's the new kid on the block. We don't have good data in pregnancy or in breastfeeding yet, but the CDC guidelines do have this interesting nuance where they kind of acknowledge that for some people who need protection from HIV, who might not feel safe with a bottle of Truvada at their home, the theoretical risk of this medicine to their fetus is far outweighed by the known risk of HIV that is transmitted during pregnancy and mother-to-child transmission of HIV. So this would be a risk-benefit discussion if you were seeing a patient who needed protection from HIV. Very exciting. There is kind of the initial green roots of a movement to make HIV PrEP available over the counter that draws from the same movement from the oral contraceptive pill. But this is nowhere near fruition. This was just published this year in August, as you can see. But my hope would be that it might be available over the counter in the coming 5, maybe 7 years. Who knows? I know that we're kind of running out of time, so I won't belabor this next few slides, but just to say that there is a literature that talks about how to discuss HIV PrEP, especially with women and especially with women of color. When we think in medical terms about how people are at risk of different diseases, people are at risk of HIV, we don't want to be telling our patients, oh, you're at risk of HIV. Oh my gosh, you could get this disease and it could be really bad for you. We really want to tell people that they can manage their exposure. They can take care of themselves in the same way that we take care of other aspects of our health. We can take care of your sexual health. Here is a medicine that can prevent a disease that we have no cure for. A lot of communities of color have mistrust of the medical system, as I think we're all aware. So really making sure that we are building a therapeutic alliance with our patients, and as we talk about HIV PrEP, and then there's a bit of a aspect of kind of self-care to it. As I said, that some of these models of describing HIV PrEP with patients talk about this is as not saying this is a way that you can manage risk, but saying this is a way that you can take care of yourself. This is a way that you can take care of your sexual health. This slide to say that there is a growing literature base to talk about how we can discuss HIV PrEP with women. Out of South Florida, there is a motivational interviewing model that specifically talks about ways to describe HIV PrEP with patients of color. There are many public health interventions and public health campaigns to help inform women and women of color about HIV and the option for HIV PrEP. And here are the resources. So you should never feel like you are by yourself. Even if you go off and practice in rural places, you always will be able to telephone your local Department of Public Health, your local HIV specialist, and failing that, if it's 2 a.m. and someone shows up in labor and you're worried that they could have HIV, you have the UCSF National Perinatal HIV hotline to call. So don't feel like you are by yourself whenever you have to talk about HIV or start HIV meds. Their help is out there for you. So thank you. That's our talk. Anyone, any questions? Any questions at all?
Well, people.
Hi, this is Katie Sempene. Can you hear me?
Yes.
Yes.
Okay. coming from above. No, just kidding. I really enjoyed this talk. I definitely brought to light that I am not offering PrEP screening to patients, and in my general practice, I very, very rarely coming in contact with a patient who is HIV positive. Those oftentimes are getting shuttled right to MFM, but take care of a lot of patients who have bacterial STIs, where this would be standard of care. So I'm wondering if you have any protocols for systematizing kind of general clinics like ours, as far as if they test positive for chlamydia, for example, kind of streamlining things from like a quality and systems perspective.
That's a great question. And the clinic that has done this really well is the HIV clinic. My hope is that most PCPs would feel comfortable managing this, but in reality do not. I think most people would order those Q3 labs as just like standing Q3 labs, and then have people come in every 6 months or annually. And when you see a patient, when you diagnose bacterial STI, it doesn't have to be that this like huge sell job. You don't need to feel like you're pushing, medicine on someone, but just bringing up, it can be even one sentence like, oh, did you know there's a medicine that can protect you against HIV? HIV is a disease that is sexually transmitted that we have no cure for and can impact your health. Is that something you're interested in? That's all you need to do. Just bringing it up is kind of my one ask. You don't know if the person sitting in front of you is being victimized, is at risk, is being sex trafficked. And, you know, we may have a lower incidence here in Wisconsin, but you just never know if that person in front of you may want that protection. So there are protocols specifically to the question. There are protocols. The HIV clinic does a really good job of this, but it's not impossible. And if you're seeing a patient annually, you can order the Q3 month standing labs and then just see them annually. And then when the refill request comes in every 3 months, you know, just make sure that they've got their labs done and then press refill. I don't know. That's kind of how I see things being done. Yeah. So anyway.
No, that's helpful.
Okay.
In our clinics, we don't provide primary care, but we do obviously OB care and STI screening. So I'm thinking like this might be something that we could maybe work offline with you about nursing delegation protocols and how to do that one-liner and things like that, so we don't miss the opportunity and kind of maybe just shuttle them into the HIV clinic or an appropriate PCP that can follow the long-term ones.
Yeah, definitely. And you know, the HIV and PCP, you know, most PCPs, my hope would be able to do this through virtual visits and telephone visits too. So hopefully to reduce the burden of making it more accessible over time. So, and
thank you so much. It was great. This might date me a little bit, but where I trained in Washington, there was a large amount of HIV positive pregnant people. And we had a specific clinic for it there. But we usually only talked about PrEP when they were wanting to get pregnant, like preconception, and they use it very limited. And so I think your message is it's being more like chronic suppression PrEP use, and just curious a little bit about like the transition to that, or maybe that's been around a long time and we just didn't do it there. But I think that's the message we're talking about. And I just didn't know that. So
for HIV PrEP, for pre-exposure prophylaxis.
Right.
Yeah. So you can start that. You know, let's say you get someone in your OB clinic, you get your initial prenatal labs and you see an STI, and, you know, you said, well, you give that spiel that I just talked about, you know, you can, in that case, have them start Truvada. Sorry, was that?
I guess what I'm asking more is like people at risk not wanting to be pregnant. Like, do you give it for years for people then?
Yeah.
And I just don't think we did that.
Oh, I see.
You see what I mean? So
right. Yes.
So I think a big take home message is that like just in the general population, people at risk, like that's being used not just around pregnancy.
Yes, 100%. Absolutely. Yes. Doesn't have to be just around pregnancy. Yes. Okay.
Hello. I am actually training to practice in a rural area. And so I'm thinking of like the actual like tangibility of these PrEP medications, like in pharmacies. Like I prescribed Lovenox for a patient who her local pharmacy had 5 doses and she lived an hour away from her pharmacy. And so trying to like actually get the medicine, you know, from the prescription to the pharmacy in the patient's hands, like what does that, do you have any insight into what that looks like in rural pharmacies of like actually getting, I don't know, like the supply chain of it all? It just seems like that could be a possible limitation.
It's available through mail order. I know Amazon Pharmacy. I don't know if we've started prescribing things for Amazon Pharmacy, but Amazon Pharmacy will. And I'm not paid by Amazon. I have no affiliation with Amazon. But they can use this available through mail order. So even if your local pharmacy doesn't stock it, it's available.
Okay.
Your question brings up we cut out some slides about post-exposure prophylaxis, but your question kind of makes me also think about post-exposure prophylaxis. You know, a pharmacy should really have some kind of HIV med in stock so that you can get someone medicine if they've been a victim of sexual assault, if they need post-exposure prophylaxis.
Okay.
So my hope would be that most pharmacies would have some kind of HIV medicine in stock at least for you to be able to prescribe and dispense. So, but you know, everywhere's different. I don't know.
Great. Thank you.
Amazon Pharmacy is great. Yes.
Thank you.
Great. Thank you.
Thank you.